for coming to our panel
Some of them even have
on climate
trays
change
or
and
pens, so
emergency
you
response.
squeeze it.
My name is Katie Myers. I am a reporter with Grayson Bush Public Radio. I cover climate change in Appalachia. And I previously, before that, worked for WMT at Apple Shop as an economic transition reporter. In both jobs, I've covered floods from the ground. So over the course of that flood coverage, I think something that's really stuck out to me in our region is the different sort of degrees to which, first of all, the sort of like public health implications of these disasters we're seeing, and especially for people who live with disability or who live with chronic illness or other health challenges. And especially that really came to light, I think, after Hurricane Helene, when we lost water in Asheville for 52 days, and we found folks who were elderly, folks who were disabled, folks who need clean syringes, and other situations, like people dealing with a lot of really severe health challenges that weren't always met. So that sort of like piqued my interest in this topic. But I'm mostly here to just ask questions and share with you experiences of Dr. Bo Morgan, or soon to be Dr. Bo Morgan, and Dr. Amanda Alexander, who all introduce themselves, and if you would talk a little bit about the populations that you serve and the work that you do.
Sure. I'm Bo Morgan, not a doctor, hoping to be a doctor. Yeah. And I'm currently a paramedic, and I'm the co-director of Hellbender Harm Reduction in Knoxville, Tennessee, where we provide syringe service programs, HIV and Hep C testing, and wound care to a largely unhoused population of people who use drugs. Through that work, and for the past decade, I've been doing acute disaster response as well as working to provide street medicine within unhoused encampments throughout the South and Appalachia. I've responded to the Kentucky floods alongside Katie, and did some relief work during Hurricane Helene. I've also gone as far south as like New Orleans and the bayous after hurricanes, and again it's just been like the state's left us high and dry. Our most marginalized populations are literally being left breathless and without care, whether up in our hollers or down in the bayous. And so it really takes a resilient community to be able to provide care within those disaster settings where our institutions have failed us and have excluded our communities from accessing care during acute crisis, as well as just like chronic disease management and prevention.
I'm Dr. Amanda Alexander. I am an internal medicine physician as well as a hospice and palliative medicine physician. I'm located in Asheville. I've been the kind of inside the institution counterpart to the work that Bo's been doing for, I think we've known each other for 4 years now.
Yeah.
Or 5, maybe this year's 5.
Yeah.
I have a background, again, in hospice and palliative medicine, specifically doing end-of-life care and chronic disease management for unhoused folks. I am the former medical director of a free clinic in Asheville that was kind of started before Hurricane Helene, but really grew and changed into something entirely different during Hurricane Helene. If you saw the article in The Nation or in Rolling Stone about mutual aid during Helene at the field hospital that popped up outside the Double Crown, which is a dive bar in West Asheville that, became the second most efficient medical system in Asheville, according to Asheville Fire Department. That was my project. We took that and we expanded that, and for a time we're providing, really comprehensive free clinic services to our unhoused population. I do a lot of research work in end-of-life management and care for our unhoused and substance-using patients, because as a hospitalist, I'm currently at work right now, presenting from my office, where I'm admitting these patients. to, in the traditional medical setting, you don't necessarily receive the full benefit of end-of-life care because there is still such a stigma in how we take care of people who choose or end up unhoused and people who are actively using substances. So, you know, my goal is by doing research, by publishing on it, by starting to write up the experiences of myself and others like Bo, we can have an evidence base to start doing this work on, because at the end of the day, it's one of the only things the system actually listens to is the evidence base. That's why we're here talking today, because this is one more thing that we can do to say, hey, we're doing this from an academic standpoint, we're not just winging it.
Thank you so much, Amanda. Now I would love for you both to speak to. You both responded to a variety of disasters over the past few years, from floods to tornadoes. I would just love to hear what it has been like on the ground, and how have you, in your medical capacities, responded?
Yeah, absolutely. I'll just go ahead and go, but like Amanda, if you ever want to go first, I don't want to hog the floor.
I apologize, I just want to make sure I'm going.
Gotcha, no worries.
But go on, I'm here.
Yeah, I think that just again and again, I've been in situations where I was thinking about it earlier, how like I'm constantly asked if I'm a veteran when I'm on the ground in like disaster settings. I'm not a veteran. I have no military background, and I think the reasoning behind that is because people who I'm working with sometimes in those settings see me as someone that's like going out, doing the thing, understands what infrastructure is needed. During the 2022 floods in Kentucky, where we saw extensive loss of life, property, and like heritage items, like with the apple shop flooding, one of the first things that happened was I was given contact info by the National Guard to like just go out. If I found someone that needed a helicopter, call them, because they didn't have the ability to actually go out and do rescue work or to do like extensive extractions. But what I found once I got out into like the hollers where there was so much flooding, I mean completely like roads washed out, and I was hiking up hillsides, was that it was really folks that were disabled, like old miners with like straight up black lung or like COPD or other health complications from doing their life's work for industries that ended up abandoning them. Like their oxygen tanks had run out, they hadn't been able to get healthcare access or care or oxygen in days to like over a week. So I was just hiking oxygen. I ran back to the National Guard hub and was like, I need all the oxygen you have. Like just load my truck up with tanks. And they were kind of like, what do you mean? Like, why? Like, that's not a big bloody mess. And I think that there's just been such a lack of anticipation for what sort of climate disasters we're seeing and what populations are being continuously affected by these oftentimes man-made disasters, and like climate change is a man-made disaster. The state's not prepared to help us, and oftentimes are unwilling to help our more marginalized populations. I do a lot of work in areas of town where there's like severe segregation or like severe redlining and under-resourcing, and it's always, and I try not to make broad statements, but it's always those neighborhoods where it's like, oh, their whole house is flooded and like they're still hanging out on the roof, or like I have to bash in someone's window to like help them get out of their house from my kayak, which is floating near the top window of their house. Like, why is this family stuck in there, and have been for days on end, while there's, you know, state resources going by on like their submersible Bearcats. It's because they're black and brown and indigenous neighborhoods, or they're poor folks, or they're the old coal mining communities that are still up in the hollers and they can't get their oxygen. And I think that I'm kind of going on a rant here, but yeah, we just have to build our own survival infrastructure, and we have to have those connections. And within Appalachia, we have that history of checking on your neighbor, of knowing who your neighbors are. And it was oftentimes folks near the front of the holler that were like, please like go up top or go up to this spot and check on Mr. So-and-so, or like, I know those folks haven't had water up there in a week, and things like that. And it was always like, oh yeah, no one's come by to check on us. And like, really just the state's emphasis on wanting to get those really, you know, like, it's very become like romanticized, especially after Helene, of like, oh, there's a doctor on the Unicoi hospital roof, and like, that's horrific. But like, there's also 30 like folks in a trailer park that have not had water in a week, and that should be equally prioritized as, you know, making sure our infrastructure is stable. And
I mean, that's one of,
yeah.
oh, sorry. That was one of the things we did as the Asheville hub during Helene is, yeah, we were a field hospital where anyone could walk up. Anyone could, you know, we had an agreement with one of our local pharmacies to provide non-narcotic prescriptions for people who had lost their medications, but the vast majority of what we were doing was coordinating the teams because the city did not have the resources to do so. We sent someone to Vital Records one day and we got the list of, here's everyone that people have been calling in to ask about. We don't have the manpower to do it. And this was a very big, broad countywide list. We were coordinating teams going out in a 5 to 6 county radius, including delivery of medical supplies and food and water and diapers out of the double count, because the systems that were in place did not have capacity for the scale of the disaster. And that was one of the kind of the most wildest things about it, is sitting on a table with maybe text message service some days, no cell service, barely any radio service, and we got a Starlink. That was the one thing that let us do this, and scrambling to come up with systems, you know, taking all of the different bits of technology that we had to make something that we could use to take the notebook and the stack of paper that Hall Vital Records would give us, and to dispatch teams with what those trailer parks needed, who the contact was, because one of the things that we really run into is you've got a bunch of tattooed punks from Asheville going out into the country and going into the same neighborhoods that Asheville has, just like Knoxville. And not necessarily the people that, you know, are who you would expect to show up, but we were the crew that was there, or we were doing it. And having to build from the ground up with essentially nothing, an infrastructure that could sustain the work that Bo and others were doing, was kind of the wildest part about it, because it was a constant flood in of, we were having volunteers after Helene come in from, I think we had NOLA, we had Atlanta, we had folks coming from everywhere, and they would roll up and say, what can we do to help? And you can't just tell people, hey, we don't know what to help, and we don't have the infrastructure that, you know, like the Samaritans had, or even to the point we had some of what Matter, which is mutual aid disaster relief, has. We had some of their stuff, but a lot of it we were building from the ground up, because, you know, I think there's I think up until Helene, even with the experience of most of us in other disasters and other spaces, I'm from the West, so wildfires are, you know, wildfire response is one of the things that we do a lot of. You know, when your house gets evacuated once a year, you know how to coordinate everybody to make sure the entire county's safe. But to build those and to create the structures that it was going to take to be able to sustain it, to get those niche areas that all of us who had done this work kind of just came together to do, to get them served and get them taken care of in ways that felt authentic and were what the community needed. It was one of the hardest parts, because, you know, it was easy when people walked up to us and said, this is what I need, I'm going to take these things, I need this medical attention. But when we're going out, it's an entirely new paradigm of how we help people access care.
So, both of you have responded to disasters across, you know, multiple states in the region, and between the two of you, so North Carolina, Tennessee, Kentucky, sounds like Louisiana, which I didn't know, and not the, extended region. But, and across our region, Appalachia it's not bounded by state borders. There's so many states with so many different political conditions in this region. I'm curious as to how, as you sort of like responded in different states, how have you seen those sort of political conditions interact with the conditions of your patients?
Yeah.
That makes sense as a question.
Yeah, absolutely. I think a great example for that is like buprenorphine access, where buprenorphine is a medication used for opioid dependence, and so you can go on buprenorphine and not feel the withdrawal symptoms, and you can, achieve whatever goals you have set for yourself, or transition into maybe like lesser use. And the laws surrounding that between North Carolina and Tennessee are vastly different, especially between like access. And so during some of these disaster responses, I was calling Dr. Alexander and being like, I have a community that's completely cut off with multiple people in withdrawal that can't get to the clinic or can't pick up their prescriptions, and I don't know what to do. There's also like not a drug supply right now that people can access because you're in a cutoff area because of the flooding or the mudslides or whatever. And just being able to have a provider and someone from a higher care institution being willing to share that information, willing to brainstorm ways that the community can meet the needs of all members where policy has failed, where they don't give advanced provision of certain medications like methadone. I think it was you and me, we met a woman in Kentucky and she was like, the methadone clinic's flooded. And like, I have to take it every single day. And you have to get methadone, you have to go to the methadone clinic every day and get your medication. It's the only medication where you have to go to a specific clinic to access it daily. And yeah, for like people like that, it's like they just get completely left behind. There's no advanced provision, there's no care plan instituted or policies in place to protect these people's health in disaster settings, or even in like, oh my kid's sick, I can't make it to the clinic today, like what does that look like? So yeah, like during these situations, just policy failure becomes such a highlight. Like it's oxygen, it's in the air, like why aren't we giving advanced provision of oxygen and like extra tanks? Just glaring failures of policy.
Question. Well, I know, huh?
Do you mind if we take questions at the end?
Okay.
I actually want to piggyback on that in two parts. Number one, the oxygen thing. The reality is we don't even have a backup infrastructure for oxygen.
Yeah.
When the companies, like one of our gas companies got flooded, we were calling dive shops to see if we could figure out oxygen and be like, hey, can we do anything for it? And we simply couldn't, because there is not an emergency provision for oxygen for people. And the second comes when we talk about buprenorphine and medication-assisted therapies like methadone, buprenorphine, Subutex, Suboxone, whatever you want to call it. This is also one of the spaces where the system fails those of us who are in that higher level of care in terms of what we can do. Because within the emergency kind of privileges that are given to providers, I still, like, because of Medicare, Medicaid, and bigger regulations, narcotics fall into that space of, by North Carolina law, I have to e-prescribe, I have to have it on a printed script. If I'm doing a hard copy, it has to be a printed script on a tamper-resistant paper. I cannot call it in. I cannot, for a lot of patients, even access it outside of, if we are in a clinic with our computers, patients just, even if our systems go down, patients have to wait for their narcotics. To the point of, we had 2 facilities that had been authorized. One was in South Carolina, one was in Asheville, to refill prescriptions for people who had lost their meds or who were due to get meds. And unfortunately, the limitations come to the point of, we want to help, we can do this, we can give you these resources, here are some options. However, we still, a lot of our providers are still handcuffed in what we are able to do because our local pharmacies weren't dispensing these. And they won't accept scripts from anybody other than your doctor, even in these situations. since that was part of the agreement I had with the pharmacy we were working with, they straight up said, you know, we don't feel comfortable doing this, here is what you can do, but we're not gonna do any of this because it creates a legal space that just continues to put our disadvantaged patients kind of further down that slippery slope of not being able to recover and go down everything, go down the whirlpool into just, not just relapse, but into unsafe, non-harm productive practices of use. So it's really frustrating to see it happen. And to be, you know, sitting on a sidewalk, meeting our portable opioid response team and being like, that, this is all we can do. We have our provider here, and we still can't do anything. We have the provider, all these patients here. There's still nothing we can actually do.
This reminded me also about just the hyper-militarization that occurs during disasters and how that impacts people being willing to like leave their houses or access care, because some people cannot safely do that if it's the military is outside or there's a huge increase of police running around. As a like white-skinned person with the privilege of having emergency tags on my car, I've still had run-ins with right-wing militias within disaster spaces, and I've still had police being like, what are you doing here? And it's like, I'm a paramedic, I like have to access my patient, and like I've been given a mandate by your EMS director to do so, and still it's like this hyper militarization of like this enemy that might be within the disaster setting, like looting, and it's like, what does that even look like? And like people are just trying to get food, and just there's so many, we already within Appalachia have so many barriers to accessing healthcare, accessing even basic needs. And then within disaster settings, you introduce so many more barriers, whether they're environmental or political. The last few settings I've been in, I've seen so many more specifically white supremacist organizations showing up, and they're extremely well trained. They have so many resources. They've got ATVs and motorbikes, and they're doing, you know, all of this work and all of this, they have all of this generators and funding, but they're prioritizing the wealthy white neighborhoods and the people that are not being as impacted, because when you're wealthy and you're white and your house is up on top of the hill that the mudslide came down off of into the black and brown neighborhoods or into the impoverished areas, you're gonna be like, all right, you've got your food, you're gonna be okay for a day or two. But it was oftentimes the militias like making a big show and filming themselves on YouTube Live or whatever, going up to these houses and being like, oh, we got a teddy bear or a stuffed animal for your kids, while people down in the hollers or down in the more affected and directly impacted areas are having acute crises from the fallouts of these climate change disasters.
So we've talked some about the
I don't know why it keeps.
I don't know why it keeps doing that either. Strange.
Maybe it's sitting on the share screen or something.
Not sure, but thank you for yeah, so I mean you've observed some gaps in, you know, who was served, even like, I'm curious to hear more about even some of these smaller gaps in sort of state and health infrastructure, sort of like formal state and health infrastructure that you observed, and just where, like, how were people that you found taking care of one another in its place? What has that looked like in your experience?
I think one of the really interesting gaps that I saw within the context of the work that I do is access to information. In the early days of a disaster, you have access to radio. You're not going to have phone. You're not going to have a lot of that. If you are a person who has access to that kind of things, you're able to stay informed. You're able to send out the messages. You're able to use your Garmin GPS thing and make sure everyone knows you're okay and download an emergency broadcast. But we heard so many stories and saw so many people who, until they came into the healthcare system, got brought into the hospital, they had no idea the things that were going on because they didn't have a radio, they hadn't had phone service, their family member had hiked 3 hours down the mountain to get to a place where they could find someone to get up the mountain, to get grandma off the mountain, to come down for, she had a stroke. That was one of the biggest things I saw, is just the lack of information created this massive gap that disproportionately actually affected our older adults and our elderly population who don't have at baseline the same access to information. It just got exacerbated to a point of the number of people that we admitted in the first month after Helene because they couldn't get information, they didn't know what was going on, they tried to do something silly, or they couldn't access care in traditional ways, was really huge.
I had that same experience time and again where I would access someone who lived in a more remote location, and they were like, oh, I thought it was just my little creek that flooded and washed out my road. And I'm like, I have to be the person that's like, no, the whole county is underwater, and I can go check on your family and your kinfolk if that's something you want and would help. But yeah, access to communication and infrastructure around who has access to internet and who can send messages has also created a hierarchy of who deserves and who is able to get care quicker and faster. Because even though our rescue teams and our firemen do an incredible job in extracting people from these rooftops or getting into areas where maybe someone's had a stroke, they can't do that if they're not notified. And yeah, it just really creates a hierarchy of access.
And how, I think I've, heard you both individually talk a little bit about the ways that people do step up. And I know I observed this in Asheville, right, with trying to remember the name of the group now. But oh yeah, people were carrying buckets of water up to elder care facilities because people couldn't flush their toilets, right? And this was something that the city sort of got involved in, but was also kind of a very community-driven effort. There wasn't a lot of formal effort to go and do this and address this potentially really problematic, huge public health hazard. So just thinking about those ways that people stepped up and took care of each other's health in those moments.
Yeah, I think there's so many good examples that the cities and I have a background in emergency management planning, and so you don't think oh, people are still going to be having sex, they might need access to emergency contraceptives even though a hurricane just hit. Truth is, people are still doing that, and they still do need access to their birth control and emergency contraceptives. And so community members, coming out with Plan B or going out with Julie or condoms or Narcan or any of life goes on. And I think it's been a real failure by the state of expecting people to panic and stay in place where that's not realistic and that's not what occurs. People still are gonna have a heart attack, they're still gonna procreate, they're still going to try and go get heroin if that's what they need in the moment. And making sure that we're able to help people do those things safely and continue to access the care that they need has been something that's really fallen on communities to make sure, and community members and underground groups or mutual aid networks versus, city or county governments aren't going out and giving people condoms during a hurricane. And understandably, there's water main breaks, but you don't want to have a ton of acute, health crises because you didn't take preventive measures just because there's a climate disaster.
That was actually one of the things we handed out probably more condoms
and
Narcan. We had a station for it, and it consistently was moving, and we were sending it out with our volunteers, and they were coming back saying, I need more. I couldn't actually keep farm production supplies in stock. That was the one thing we were getting deliveries of farm production supplies from, I know Bo, you sent a bunch to us. That was the thing we were starting to ask for.
Yeah.
were harm reduction and Narcan and condoms and things like that because people they needed that, they were asking for that. It was part of it. It was that and diapers.
Yeah.
Those are the things that we needed. We needed more than anything else.
Yeah.
It was Narcan and diapers.
Yeah, it's really scary when you find a parent with an infant that's like reliant on a specific like hypoallergenic formula and you're in a disaster zone and the National Guard is like posted up outside of the Dollar General making sure no one even goes near it when that parent can only get to that one Dollar General to access baby formula, and you're seeing like community members their health just like plummet because now you have neonates drinking water, which if you don't know, your baby shouldn't be drinking water. And things like that, like it's just like this systemic, almost like a criminalization of people that are affected by disasters, where you're almost blamed for it, and you're blamed for not being prepared enough, and like whatever health outcomes you experience during that like peri-disaster occurrence are somewhat your own fault. And that sort of projection from government officials or emergency management is again putting the burden of care back onto communities, and especially women and femmes within those disaster settings to sort of maintain the societal expectations of that caregiver role.
Yeah, I wish I had thought to pull up these numbers in front of me, but I've been speaking with some researchers at the National Centers for Environmental Information, which is like a division of NOAA, about post-disaster health, and they studied, I think it's 3 months after Helene, but are continuing to track like ER visits and like sort of like chronic health conditions emerging, and then just found that for everyone, especially for pregnant people having children, but like for everyone, the sort of like deferral of care has like elevated like or intensified chronic health conditions, and like probably will continue to. And there's lots of other peer-reviewed research out there about how death of all causes increases in the 10 years after a disaster. It did after Katrina. It has after lots and lots of disasters for lots and lots of reasons. But we can kind of see some potential reasons why. I'm curious. I mean, I've so much of, and in speaking to health providers, and especially people who work in the harm reduction space, I've heard a lot about like how the response, the sort of like ad hoc like response like filled needs, but I think like when I hear about that, I have a question in the back of my mind about like how do we institutionalize that? How do we make it permanent? That people get saved, that their lives get saved, with the supplies they need and the help they need. At the policy level, like to serve the vulnerable populations that you both serve, what policy changes do you think need to be made? If you have any thoughts on that.
We need decrim of substances. That would start it, because then people could actually seek resources. We have the data out of Brazil and Portugal, and we have the data out of the supervised consumption sites in Toronto and the Netherlands saying that people have better health outcomes when we have either decriminalization or better access to support. In a disaster setting, that would take one level of the criminalization away. So.
Yeah, I think that would be an incredible step towards other countries do this. We saw Toronto in Canada provide Dilaudid to people using opiates during COVID, so they had a safe supply of substances where they could use safely at home. I think other policy changes would just be, honestly, like the whole system is so broken. I honestly like hate talking about policy changes because I'm like, this whole all the policies are like so racist, and like people are still, no matter how much we tweak it, like we're not going to be able to fix it. I think that replicating mutual aid networks in small community settings and just being able to rely on each other is so important and so vital to community health. And I also think we should have a broad mentality of caring for each other, and I don't know the answers. I don't have a good answer for that question.
It's a hard one.
Yeah, I think everything's bad. So.
Yeah. It's interesting because I've heard some little things like I talked to I'm working on a story about you know, people who use drugs and the sort of like interaction with climate risk, especially after Helene. And I've talked to some folks about how they're just it was difficult to get things like clean water out to people, and like the sort of small, like the large effect on health and safety that like having clean water to like clean your syringes, you know, would have in like preventing sepsis. So those are some little, I feel like they're little things I've heard here and there, but big. But it's, yeah.
Oh, go on.
Oh no, that's all. Go ahead.
I mean, we could also take it from an insurance industry standpoint. If the insurance companies would actually pay for post-acute hospital care, like skilled nursing facilities, rehab facilities, and having transitional housing facilities for patients who have a tenuous housing situation in a climate disaster, that would fix a lot of it. The number of, we actually had a defined statement that we put in our documentation. This patient's hospitalization is extended due to circumstances created by Hurricane Helene. For that part of, they do not have a safe discharge plan home. We can discharge them to the streets, or we can keep them in the hospital. I am lucky I work for an institution who felt right and good about keeping people in the hospital until we could find them somewhere safe to go. But I know from my colleagues in other institutions that they were fighting a lot harder to keep their patients here, to give them somewhere safe to go, because we were at a direct head-to-head with insurance companies, because we had rehab beds available and skilled nursing facility beds available. We had options, but getting those covered by insurance companies, if we can fix that, a lot of our climate mitigated risk can happen. I think, you know, there's places like Haywood Street Respite in Nashville that are trying to be a kind of bridge facility for medically complicated individuals experiencing homelessness, but it still doesn't change the fact that somebody has to pay for this care. And we all know that the changes to Medicare and Medicaid that are coming up are going to make this even a bigger issue outside of the climate disaster, because they're making it harder for patients to have their nursing stays covered. And that's just for a post-hospital stay. That's not even talking about the care that our disabled and more marginalized individuals who require 24/7 nursing care are gonna need. So we can fix that. That's one more, that's a rant. That is a rant.
Yeah, I think also like disaster planning around how do you extricate someone in a wheelchair, just really basic disability justice within climate disaster settings, where it's like you have rescue squads with these boats, and they don't, you know, they're not trained in how to like safely move someone with cerebral palsy out of their house, maintain the safety of their mobility devices, and extract them from a dangerous situation. And also doing so like through, I'm a bit of a hard ass, and I don't like to get super woo-woo when I'm in an emergency setting, but like through a trauma-informed lens, because disasters are traumatic, and we don't want to increase the trauma by, you know, making someone leave behind their mobility device, or leaving behind medications, or a service animal. Yeah, I've seen that. I've seen people like devastated at wherever they got brought by folks, and they're just devastated because their service animal wasn't able to get there, or they've refused to leave an unsafe situation because the service animal wouldn't be accommodated.
Or refused to be admitted.
Yeah, absolutely.
It's an everyday thing, even post-disaster.
Yeah.
It's just a big problem.
Yeah, I mean, we're obviously talking like acutely about and specifically about climate disaster and like things like hurricanes and flooding due to like coal extraction. But I've done rotations in hospitals where it's like there's foster kids living in the ER, and it's like a hush-hush situation where like there's doctors and nurses checking on them and like showering them, but there's like a literal foster child living in the ER. And expanding that, like our healthcare system is a disaster zone. And I think that going back to my initial introduction, I think when I'm talking with like less context about the things I've seen or participated in, people get the impression that I'm a veteran because the things I'm saying sound like, you know, not of this area, or sound like things that we're conditioned to believe don't happen here, or only happen in like under-resourced countries, but they are happening here. And I think that plays into a lot of the assumptions that like, oh, I must have like served overseas or been in the global south, where it's like, no, that was literally down the street.
I'd love to just ask you guys before we open it up to the room for questions, is there anything else that you would like to speak to, you know, when it comes to your experience providing care in disasters?
Just like the people know what they need, and just always like, I trust them. If someone's like, I don't know, sometimes something can seem like stupid and I'm like, what do you mean you need like purple like soft socks right now? But like they need that, like that, I don't know their history, maybe like their mom gave them a pair of purple soft socks and they lost them in the flood and that's like their thing. And like people know what they need, trust them, and like get them that stuff, validate their experiences. My go-to phrase is just like, this sucks, cause like it does suck, disasters suck. And just being there with another person, and not, even if you don't know what the right thing to do is, maybe like, I'm just a paramedic, I'm not a doctor. I call up Dr. Amanda sometimes, but a lot of the times I just say like, this really sucks, like there's not something I can do because there's no infrastructure, there's not, like I can bring you your oxygen, I can't remove the nodes from your lungs from working in the mines, or get you an actual livable disability check. So like, it's a repeated exposures to acute disasters, whether we're framing it disaster as like climate change or just the failure of the healthcare system to care for our communities. And I think like people like to talk about post-traumatic stress, but when you're working within these disaster settings or with marginalized populations, it's really not even post, it's reoccurring trauma that's like—
It's CPTSD.
Yeah,
It's
CPT.
complex PTSD is what
Yeah.
by definition what it is, and it's what we deal with every day, because like both said, it's really easy to try to fix the symptom, but until we fix the underlying diseases, we're not gonna actually be able to sustain meaningful improvements.
Yeah, because I can hike as much oxygen up a holler as I can, but if no one comes and fixes this PFAS bridge so he can go get his oxygen, I can't stay there forever doing that. So like, what kind of infrastructure do we need to like get these needs met in an efficient and equitable time frame that like serves our communities and doesn't just say, well, this population is disposable.
Thank you both so much for everything you've shared.
Thank you.
I want to just open it up for questions, discussion. We can just talk and chat, because I'm curious to hear what experiences are in the room. But yeah, feel free to ask a question.
Okay, I know climate models say events like Helene probably will become increasingly likely in the future. Have you had discussions with patients or individuals about that, and why steps need to be taken to mitigate that risk?
I have a lot of conversation. I work almost exclusively providing care in encampments at this point, and with unhoused people and people specifically who use drugs. And even more specifically, drugs that can cause like like potentially lethal withdrawal symptoms via like seizures or other pathologies. And I do talk to people about like, try your hardest to have a bag, like keep an extra bag on you. You don't know how the supply is gonna be affected. And that's not really like within a climate related setting, but like having a huge drug bust in our town where like 10 to 15 people who are selling drugs are arrested really impacts and makes more unsafe our localized drug supply, where people have to then switch to a new provider and get their substances that they're not familiar with, and the potency is different. And I try and really encourage folks to like keep at least like one dose of whatever your drug of choice is on you if you can. Because that way, if you're arrested and you just got out of jail, you at least know what you've been working with. You can use slowly and reacclimate yourself and your tolerance. Yeah, just really trying to encourage people to like think about how their being criminalized could result in their fatality, because I've oftentimes seen the criminalization of identities and lifestyles and people's race result in death. And it's almost always preventable death.
Yeah, and from a standpoint, kind of the other half of that is, you know, when we do discharge planning, when we admit people, one of the conversations I have is, okay, so what are we gonna do at the end of this? What is your go home? And we include, do you have access to clean, safe running water? Do you have adequate power supplies? You know, do you have a primary care that I can say, hey, this person's gonna need the letter from Duke Energy to say they qualify for free energy to run their CPAP and their oxygen concentrator? Do you need to be plugged into a 540B pharmacy so you can actually afford your medications? You know, the global climate disaster is tied to everything else that is going on in the world that is making it harder for people to survive life.
Okay, well, I'm sorry, my question was more like, you know, taking steps to mitigate the climate change, like moving towards renewable energy, or
Yeah, definitely. I definitely encourage people
having those kinds of discussions.
Try and do things like that. But I think that like you can recycle all you want. At the end of the day, the US is the biggest contributor to climate change in the whole world because of US imperialism and the militarization that we try and blanket the entire globe with. And even in just the last few weeks, we've spent hundreds of billions of dollars on an imperialist vision in Iran, where that could have paid for, I think I read like 23 million people that are unhoused to gain access to housing. And yeah, I think like colonialism and imperialism at the end of the day, like you can recycle all you want, but like until we have an anti-capitalist view of how we're gonna access healthcare and how we're going to like grow food or house each other or treat the actual earth, they're like, we as individuals, we can't be responsible for the US government polluting the earth and destroying the climates and like going into Brazil and producing so much meat that their forests are devastated. It's just an endless, you know, I can go on for 5 hours.
I'll speak from the climate reporter's perspective, where I don't know if this answers your question, but I have seen some interesting like microgrid type stuff happen since Helene, like as a result, where like there are interesting like small scale sort of renewable energy solutions that are helping to meet like emergency needs. So I think that's a direction people may be headed in, like this organization, the Footprint Project, which I believe started in Louisiana, is building like I think 14, maybe more microgrids throughout Western North Carolina to like create emergency energy for people. I know like Firestorm Books in Asheville like also got hooked up to one, so they can be like a mutual aid hub, like with a fridge, which like talk about one thing you need for some medications.
Yeah.
You need a fridge.
Yeah. I have a tiny solar panel that hooks up to a little tiny refrigerator, and like I can keep my friend's insulin in it when needed. And like a other organizations have done a lot of work around like solar access within disaster settings so that people can charge their phone and try and contact their family members or call in a prescription or access care that they need, alerting emergency services. And so like we have the ingenuity and like the ability to care for each other in the ways that we want to see be happening. It's just an issue, in my opinion, of like prioritization and disposability politics.
Okay.
So as like healthcare providers, how are you staying motivated, like knowing, like seeing your patients in this way, but also knowing that the climate disasters are going to continue and become worse? Like, how are you taking care of yourself and like staying motivated?
Oh, sorry, go ahead, Dr. Amanda.
I'm just completely, totally insane.
Yeah. I was gonna say the same thing.
What other option is there than to keep taking care of our patients? A lot of that, yeah, sure, we can attribute that to the inclusive nature of medical training and the way the fact that the system prioritizes you not taking care of yourself, and that's beaten into you over medical school residency fellowship. That's a separate panel. I'm happy to talk on that at length.
Yeah, I would agree and say I'm just fueled by rage at this point. Like I used to be like, I got into stuff decades ago through like Earth First, and I was like, we're gonna stop this coal reactor from coming up 81. And like I wanna do that so that little baby cows can enjoy a pasture somewhere. But now I'm just like, I want revenge for my patients, cause like just recently, like I had a woman die in my arms because the hospital turned her away, EMTALA violation, while she was seeking care because she refused to sign their intravenous drug user contract, which phones or any visitors, and she ended up dying. And so at this point, I'm just fueled by like, I want revenge for my patients. I want to take care of them. Like I love them. But yeah, rage.
Rage, yeah, I can.
Yeah. I'm not good at self-care. I'm purely filled with rage.
Now we just gotta get you through med school, buddy.
Yeah, I will be an excellent doctor though.
Other questions? Anyone else feel about rage?
I do, yeah.
Yeah.
I have a question which I'm not sure how to, exactly how to say, but maybe you can help.
Yeah.
Okay, I work for a nonprofit that is recognizing the mental health impacts of like unclean water and facing floods a lot and so forth. So we are working on some grant applications, and we were initially trying to do a survivor to survivor project where people could work, talk with each other about their experiences, and then to help document it for themselves, but then they could decide whether it was shared with anybody or not, and so it wouldn't be like mining their trauma for some oral history project.
Yeah.
But that has not found a donor, but we are looking for, Robert Wood Johnson has something that deals with health and water, and so sorry for going on and on.
No,
But anyway,
no,
I'm trying to
please.
get at this thing. And so we're looking at creating a proposal, but it does sort of require an international component also, which is interesting. But so I guess what I would like to ask you as people on the ground and stuff, as far as like working for trying to help improve situations around mental health and access to water, or access to good water, clean water, or disaster resilience. Do you have any words of wisdom of what people really could use, or what would really make an impact, perhaps?
I think just, like you're saying, access to water, like just getting it from point A to point B, and point B being the people that need it, and having having those infrastructures in place prior to disaster. I think we were in Kentucky and there was like a semi-truck load worth of water, like cases of water just sitting on the side of the road. And folks like elsewhere really needed that water. And so I think the disbursement of how like more populated areas get prioritized and making sure you're like getting into really rural areas, because like they really need water. They have the pathologies of like having had to drink not safe water, or even injecting with unsafe water. Yeah, I think like we would go into just like really rural areas and there's no, you know, big church van full of supplies. There's just nothing. It's just pure desperation and like folks fighting to like keep their families safe.
I also think you come at it from a little bit different perspective. Do a combination of education in terms of here's how you can create safer water systems. Like here's a map of potentially potable water sources. Here are 4 different things you can do if you are in the absolute worst case scenario to have safer water. And then combine that with essentially, you know, so I've done this with previous nonprofits I've worked with. You have an outreach kit that has kind of 1 or 2 items plus an educational pamphlet that says, okay, here is a water container. Here are 2 different filtration methods, like a pack of iodine tablets and a life straw. And here is some kind of easy to digest education so that you can understand the impacts of not drinking good water. Because I think one of the things I saw a lot of is people not actually understanding the full impact of what they're doing. They're gonna do it because of desperation, but if you can provide them a little bit more insight and understanding as well as some tools, people can actually get their stuff figured out. And if they have the resources, we're in Appalachia, people are resourceful as shit, as long as they know what they're gonna do with it. I think you could also combine that with prioritizing more rural areas for access, but specifically saying, hey, here's how you can do it better. Here's, you know, we handed out a lot of, for our folks who are using substances, here is the priority list of what I would like you to use to inject with if you cannot get sterile supplies. Or, you know, we were doing a lot of work in the neighborhoods being like, hey, please don't use the creek water to flush your toilets. It's gonna do X, Y, and Z to the water supply. Here's how you can do it instead. And making it really easy to digest and understand. So providing, and then giving people enough of a little bit of a start on doing this. Because, you know, not everyone's gonna come from the space that a lot of us are in of like, I grew up on a well and a spring. We've been filtering our water in various ways since I was, you know, born, so we know what to do when things go bad. Most people don't have a good concept for that. And so making sure that they have access to the things they need to do to live a little bit better and a little bit safer can be one of just the non-disaster type things that we do. And doing outreach and all of that, it's what we do with harm reduction, and we know it works. And it is essentially water harm reduction.
Yeah.
Okay, thank you.
Thank you.
Well, not really a question, so I apologize for. I live in Eastern Kentucky. I survived 2 bad floods, and I have 2 rare diseases that kind of require treatment and special foods. So I appreciate what you all are doing. After the 22 flood, my partner was doing a lot more like distribution of supplies, and she was able to like sift through things and pull out stuff through the first few days that I could eat. And I'm just like underscore what you're all saying. Like I use medical cannabis. All my doctors know about it. It's official. I could get it from a Kentucky pharmacy eventually, but like after I used to live in New Orleans also, like after hurricanes or floods, even people that have like legal networks, like for that, like your regular pharmacy might close, and then like your herbal pharmacy might be closed too, and it's like there's a lot of scrambling around. But I've just decided to be a citizen lobbyist around rare disease and access to healthcare. And I'm just in a mindset right now about policy where my righteous indignation is channeled in the idea of rights. Like I don't want to correct the bureaucracy. I want the bureaucracy to be corrected based on what my rights are.
Yeah.
I don't know how to put this, but it's like, I want to have also, there's like the right to, we might need to fight for the right to have flood insurance for our houses too. But like I'm afraid like in my part of Kentucky, like people are moving away even more, and like now I'm saying some things. We have the right to live here.
Yes.
And we have to organize things around that.
Yeah.
All right, that's all. But
I love that.
was it a question? All right.
Yeah, I think that gets at like the core of what we're talking about, which is like we have the right to be like disabled, we have the right to be drug users, we have the right to like do whatever we want and still get healthcare. And like this, I have celiac, so like the food thing in disaster zones, I'm like, I can't eat all of these donuts all these churches are donating. Like I have to just like bring a bag of apples with me every time. And so like just really like the right to exist and like not to be named as a disposable like casualty just because you live in a certain region, and specifically in Appalachia, is just like duh, like let us exist. I'm feeling a lot of that lately where I'm like, I feel nervous working in medical systems around children because I've had a parent like rip their kid away from me and be like, you're a tranny. And I'm like I deserve to be here. And having, you know, our identities criminalized within disaster settings and like being looked at as like an other because I'm not the stereotypical Appalachian or not seen as what we've been told is that. And I think everyone sort of experiences that in a disaster setting with marginalized populations getting even more of it. But yeah, I just loved what you said, like we deserve to just exist.